welcome to Medical Round. We have special rounds today, courtesy of the clinical teaching units, and we will have 4 speakers today. So I will do a quick introduction. Just before I do that, a reminder to please enter your questions in the chat, and we'll go through as many questions as possible. And please let us know that you were present at today's rounds by answering a brief survey that will be sent to you immediately after the rounds. So I'd like to just introduce, so as I said, today is a clinical teaching unit rounds presented by that team. We have 2 resident speakers and with 2 attendings. So we will have Dr. Marc-Antoine Lepage, who is a 4th-year GIM resident and critical care medicine resident, and Dr. Yuming Wang, who is an R4 GIM resident. With our attending staff, Dr. Michael Libman, who, as you all know, is one of our ID physicians, head of the Tropical Disease Center, and Dr. Cedric Yansuni, also from the Division of Infectious Diseases. So I will give the floor to Dr. Marc-Antoine Lepage as the first speaker. Marc-Antoine, welcome, and thank you for presenting. The floor is yours.
Thank you so much, Dr. Jennedy, for the kind introduction. So I will dive right in the interest of time. So we have no conflicts of interest for the presentation. And I kept the outline as mysterious as possible as not to spoil the diagnosis. So we will go right in. And I wanted to take a brief moment to say to all the brilliant clinicians that were involved in the patient's care that some of the chronology and the clinical clues were reorganized for a better storytelling today. It's the case of a 26-year-old gentleman who presented in August in the Montreal General Emergency Department with 48 hours of fevers, myalgias, worsening fatigue, frontal headaches with sonophobia, as well as left stabbing chest pains. He was previously healthy, lives on the South Shore with 2 asymptomatic roommates, and he works in a wine cellar store. He's unvaccinated for COVID, takes no medications, no drugs, does not smoke, and only rarely drinks alcohol despite his living. On review of system, you have no other pertinent findings, including no recent outdoor activity or travel. He says, however, that a colleague of his at work was admitted to the hospital recently with similar symptoms and was told that she caught something from contaminated water. Unfortunately, you don't have a name for that thing. On exam, you have an objective fever of 39.0, and on physical, there is nothing otherwise, including no meningitic signs. You have no previous investigations on DSQ to compare with. And so initially what you find is on the CBC, a lymphopenia, a thrombocytopenia. The patient has a mild transaminitis with a normal bilirubin and alk phos. His CKs are normal. His inflammatory markers are quite high with a CRP of 200 and a D-dimer greater than 4. The emergency room physician performed an LP, and the cell count and chemistry is completely normal. The patient also got a COVID, PCR, multiplex, and monospot that are all negative. Serologies for HIV, hepatitis B and C, and syphilis are also negative. A CT head was done and negative, and in the context of the left-sided chest pains and D-dimer, a CT-PE was done that showed no PE, but a few scattered infracentrometic nodules, one of which we can see here. So you first conclude that this might be a viral syndrome, and you send the patient back home because he's otherwise well, and you ask him to come back a few days later to ensure that the blood and urine cultures are negative, and suggest that he can take painkillers PRN. So he comes back a couple of days later with a persistence of his original symptoms, and he now acknowledges to you that he had been having bilateral testicular pain since the beginning of the other symptoms. He also now has a new epigastric pain, and he had time to discuss with his mother, and he found out that she had just been started on hydroxychloroquine for lupus. So you ask for some follow-up labs. His blood counts are stable. The lymphopenia and thrombocytopenia are persistent. His CRP is rising now 300. His transaminitis is way worse. He also now has an AKI. His blood and urine cultures are preliminary negative, as well as the CSF preliminary culture. A CSF biofire was also performed and negative, and the biofire includes the most common bacterial and viral meningitis, as well as crypto, but does not include everything. So in view of the findings, you ask for an abdominal and testicular ultrasound with Dopplers that are completely normal. Puzzled by all these clues, which you don't quite that don't quite fit together, you decide to admit the patient for additional tests and ask for some help as well. So with ID, you ask for additional serologies that are all negative. You ask for an autoimmune panel, including a vasculitic panel that eventually will turn out to be negative. A UPCR is normal, and your colleagues from nephrology spun the urine, did a microscopy, only found some muddy brown casts consistent with ATN, given the poor PO intake in the last few days, insensible losses, NSAIDs used, as well as a recent contrast injection. So puzzled again, you decide to question the patient once more, and this time around his mother is at the bedside, and she's a nurse from CHSLD. So as you question the patient, she says, "Did you tell them about the lesion on your right flank? Wait, I still have a picture on my phone." So you can see here this plaque on his right flank. And then she says, "Did you tell them about your weekend playing field hockey?" So it turns out that a few days before presentation, he had been playing field hockey, and there had been heavy rains before that. So he had to go get the ball in swamps around the field a few times. So with these new clues in mind, and also speaking to your colleague from ID who has friends on the South Shore with a few anaplasma cases, you decide to do additional tests and empirically start the patient on doxycycline. So although there were never any cases in Quebec, you asked for babesia, for anaplasma, given the story on the South Shore with a smear, Lyme antibody, rickettsia antibody, as well as some mosquito-borne illnesses antibodies. The patient gradually improves over the next few days and is eventually discharged with a 2-week course of doxycycline and a follow-up to ensure further resolution of labs and symptoms. So this time around, you conclude that he might have a tick-borne illness, especially given the plaque on his right flank, Lyme versus anaplasma, who knows, or perhaps another environmentally acquired pathogen such as zoonose. So you see the patient in your clinic, and he is now asymptomatic and back to work. The investigations done for tick and mosquito-borne diseases were all negative. However, someone had thought about zoonosis and asked for a urine leptospirosis PCR as well as serology. The serology is negative, but the urine PCR turned out to be positive. So you then think that the patient possibly had lepto, and lepto you might know as one of its other many names here. And how did he get it though? So perhaps from the contaminated waters where he played field hockey. So that's your third conclusion. And the patient died any rodent or wild animal exposure. Interestingly enough, a few months later, you're in line at the Palais des Congrès to get your third COVID shot when you meet with Dr. Liu, who had been on the case as well. And she says, "Oh, did you hear about our patient's sister? She got admitted in another hospital with the same symptoms, and she actually turned out to be lepto positive as well." So in conclusion, the patient's family had taken a trip to the States with their dog, and that's probably that possibly is how they acquired lepto. So now that we've gone over the case, let's briefly talk about lepto as well. So leptospirosis is a spirochete bacteria with 10 pathogenic species and more than 200 pathogenic serovars. It's the most widespread zoonotic disease in the world and most common in tropical and subtropical climates. About 1 million people will get infected every year worldwide, with around 6,000 deaths. There are a couple hundred cases in the States every year, and they're most likely underreported and under-recognized as well. So the cases probably are much higher. Half of those are in Puerto Rico and a significant proportion otherwise in Hawaii. Leptospirosis is spread by the urine of infected animals, and you can get infected with contact with floodwater, rivers, streams, sewage, wet soil, or if you ingest such contaminated waters. The bacteria can survive for weeks or months in the urine. In urine contaminated water, and it has to go through mucous membrane, conjunctiva, or skin cuts and abrasion. Dr. Yansuni, would you like to say just a brief word here?
Yeah, just briefly, the leptospirosis life cycles are actually confusing to read about because often if in references, you'll see a figure like this, but in fact, there isn't just one life cycle or one epidemiologic cycle for leptospirosis. And so in the tropics, often it'll be associated with the rainy season, and where you come into indirect contact with the excretions of other animals because sewers are open and they overflow. So flooding, rainy season in the tropics. In temperate regions where it's less common, it still could be water associated, but then it'll be often in the dry season when areas of animal urination or micturition get concentrated and less wet. So those are like opposite things, but they reflect the same thing. It's also, there's a known animal, professional animal contact cycles. So abattoir workers or other people who are or trappers. Even in Quebec, about 9% of people in Nunavik and James Bay are seropositive for leptospirosis, and that fraction is increased among hunters and trappers. And then finally, in urban areas where most of us are going to be are going to encounter patients, it's really associated with rodents, and that is the main vector. So there are mammals. While lots of mammals can be infected, only a few of them are thought to be maintenance hosts. And for instance, the dog, peridomestic, small mammals, and cattle are maintenance hosts, and they excrete a lot of viable leptospira in their urine. But horses, on the other hand, and humans are infectable, but perhaps because of the pH of our urine, human to human transmission is thought to be relatively infrequent. And we know that leptospiras excreted from humans aren't that viable in the environment because of things in the composition of our urine. So humans, horses, and other mammals can be dead end hosts instead of what's called maintenance hosts. So it's hard to read about. Don't read too much into the drawing, but the idea is you need direct or indirect contact with urine of something, and that can be via water. Thank you for the interlude.
Thank you, Dr. Yansui. So there have been also several outbreaks linked to sport events, most notably triathlon because of the free water swimming part. And in Canada, we have had a case reported in an expedition race as well. So leptospirosis can present with many different symptoms and signs, usually after an average of 10 days after the exposure, with abrupt onset of fevers, rigors, myalgias, and headaches. And the conjunctival suffusions, which you can see here on the picture, can also evolve in hemorrhage, and is quite not unique, but it's an important feature of lepto when you investigate for a fever of unknown origin in a patient. Not unknown origin, but a febrile without a cause. So you can also have respiratory symptoms, GI symptoms, and some more systemic symptoms as well. For more severe cases, which account for 10% of patients, the case fatality rate can be as high as 15%, and you can see aseptic meningitis, which most likely is a host immune response, although you can have positive PCR in the CSF. You can also have organ failure, so liver, renal, pulmonary as well. Some neurological symptoms, myocarditis, rhabdo, and even vasculitis with necrosis of your extremities. The illness can also present with a biphasic pattern. So during the first phase, you'll have the acute bacteremic phase lasting up to 9 days. And then you can have an appearance of resolution with no fever before it all comes back with fevers again, and now perhaps even end organ complications during the immune phase. And during that phase, the bacteria can be absent from the blood, but can start to appear in the urine from shedding. Just a brief word on lepto in pregnancy. It carries a very high risk of spontaneous abortion. There are reports of transplacental infection, but only sparse data on neonatal consequences. Dr. Yansuni, the floor is yours.
Thank you. So we're going to make a brief digression on the diagnosis or the approach to diagnosing Leptospira, because in this case, it was diagnosed with urine PCR. We've had a few cases, I think 4 or 5 that I was able to verify this year at the MUHC alone, and they've been diagnosed with a mix of serology, blood PCR and urine PCR. And so I think there's a fair bit of acquirable pearls in the diagnosis of leptospirosis. So the first thing you need to understand is the time course of the disease, and understand that oh, sorry, next slide. It's clicking, it wasn't doing it. Thank you. So the choice of tests, either PCR or serology, and the expected accuracy of those tests will depend on the timing of the illness, the history of antibiotic use, and which specimen you use. Next click, please. So blood, the presence of leptospiras in biologic specimens also varies with time. So blood and CSF are relatively early and relatively short-lived, and urine can harbor viable leptospira for weeks and sometimes even months. And so, I suspect that when we talk about the bacteremic phase and the immune phase, this is really what it's referring to. It's the fact that after about a week, you don't find it in blood anymore. It's not necessarily that it's an immune phase per se without the presence of bugs, because bugs are clearly still in your body. We know that a variety of toxins are elaborated that have a cytopathic effect on mostly monocytes and polymorphonuclear cells, and they seem to have some different tropism for different organ infections. So when we say immune phase, that means it's not in the blood, but there's still some around elaborating evil humors that are causing destruction. And so click, please, thank you. So when we talk about the accuracy of different tests, most studies are using the classic microscopic agglutination test serology as the reference standard. Next slide, please. So thank you. So there's a surprisingly useful Cochrane review, useful for once perhaps, in that's on nucleic acid and antigen detection tests for leptospirosis. And it's 163 pages, so I won't bore you with all the details, but in this systematic review, where they defined a case as MAT positive, either a single titer that's high or a seroconversion, they looked at the accuracy of different nucleic acid amplifications. And what you can see here, this is a summary rock plot where individual studies are the open circles, and this ellipsoid is the 95% confidence area. And what I want to highlight here is that, it's not perfectly accurate. So if you have assay or studies that are showing very high sensitivity, it's not always coincident with high specificity. And so you can have, this is the summary statistic where you have only 70% sensitivity and let's say 95% specificity, but you can see that there are point estimates all over the map. Next click, please. And so if you restrict to studies that are using real-time PCR, which is what they use at the NML when you send your analysis in Winnipeg, this is the overall rocker. So you can see it's not perfect. And so the question arises is that, hold on, how come a positive PCR might be non-specific? And so next slide, please. This has raised a lot of questions about the reference standard that we use to define diagnostic accuracy in leptospirosis. So this is a very nice paper that's been replicated elsewhere by Nicholas Day's group at Oxford in Southeast Asia. And so next click, please. They used all available diagnostic tests and used a latent class model to try to compute an overall sensitivity of culture plus serology when you take into account all of the information available on that patient. So antigen testing, PCR testing, clinical course, response to treatment, and you can see that, in fact, what they come up with is fairly dismal sensitivities for culture and serology, and these are the specificities. And what that means is that any test that's more sensitive than this garbage test is going to appear to be non-specific. And so that's the short explanation of the Cochrane review that I just showed you, is because the reference standard is garbage. So next slide, please. So where does that leave you in real life? Like, what should you do? And so if you have a patient in whom you suspect leptospirosis, next click, please. The first thing that you should do is remember or look up the biology of the infection. You need to know what to send and when to send it. So if you're not sure, send serology and PCR. And for the PCR, you should send both blood and urine. And if you have CSF, it's not unreasonable depending on the situation. But I think blood and urine and serology are standard. This is what should be sent. It's not either or, because some will be made with some diagnosis and some will be made with the other. And when we send for serology, what is done is actually not the MAT. What's done is an IgM, and some of those. I just called the person who coordinates the testing for Quebec. Basically, all of the positive IgMs seem to have been confirmed, but if you get an indeterminate IgM, none of those have been confirmed by MAT. So there's a lot of wobble in the certainty surrounding a serological test result. So you should send both. And then, because there is some residual uncertainty, you should only send it if it makes clinical sense in the setting of a compatible patient. And then next click. And you can increase the specificity of a positive, let's say a positive IgM, by having eliminated pertinent other infections. So in this case, we talked about some, could this be, he's in the Eastern Townships in summer, could this be a tick-borne infection? So you should know, at least on the differential diagnosis of a febrile illness with or without a clinical focus, that you might include disseminated Lyme disease, you might include anaplasma, which is an emerging and probably quite serious infection in Quebec, and others, right? So that's important. And then next slide. So I gave you this long preamble so that you can make sense of what is otherwise a fairly incomprehensible table from CDC. So when you look at these summary tables with all kinds of tests, what they're saying is send both, and for PCR, send urine and blood. Boom, done. That's the take-home message. And so I think I'll hand it over now to Marc-Antoine to wrap it up.
Perfect. Thank you so much for this. That was great. So for mild diseases, really the main antibiotic, or the antibiotic of choice, is doxycycline for 7 days. And you have alternatives here, but there were never any head-to-head randomized control trial comparing these. And it's the same thing for severe diseases. So you can use penicillins instead of doxy, but again, no head-to-head trials. How do you prevent yourself from getting lepto? So obviously, if you can avoid the exposures, that's the main thing. If you wear PPE, not masks, but things like rain boots, making sure that your cuts and abrasions are covered with waterproof material. Only drink potable water. And unfortunately, there are no widely available human vaccines, and those that exist are only against a specific serovar. There is perhaps a role for chemoprophylaxis with once a week doxycycline in people that are high risk in an area that is endemic. And this is, for example, an RCT that was done with the US Army in the 1980s and published in the New England Journal of Medicine, where they showed the reduced attack rate with preventive measures with doxy once a week. There have been a few reports in the States of humans getting infected by their dogs, or their dogs being infected, and some outbreaks in LA and New York City. And so for dogs specifically, you can have vaccines which include 4 or 5 serovars, covering the most frequent ones in those areas. In Canada, this is a summary of confirmed and suspected cases over the span of almost 10 years. So you can see that is most frequent in Ontario and Quebec. hopefully we won't be seeing a dog freedom convoy anytime soon. So thank you. And in conclusion, severe infections that are linked to environmental exposure can definitely be acquired in Quebec. Pertinent environmental exposures not only include travels and all, but also freshwater exposure, insects, ticks, domestic and peri-domestic mammals, amongst others. The differential diagnosis of a febrile illness without a source in Quebec also has to include tick-borne infections such as anaplasma and Lyme. And there were never any cases of babesia, but perhaps also include babesia, and also zoonosis such as leptospirosis. And if you're not sure about which one, you can definitely ask your friendly ID micro expert. So thank you so much again.
Thank you for that fascinating cases, Dr. Hamsouni and Marc-Antoine Lepage. Really excellent case. I think we had said that if we ended at 12:25, we would move right to the next case, and we'll leave the questions till the end so that we have time at the end. There's just one quick question. I live on a farm with a dog who drinks from puddles, raccoons, and a kid running around. Should we vaccinate the dog, keep doxy on hand, MAT tests? Thanks. One quick question for you. I don't know, Cedric or Marc-Antoine, if you want to answer that.
I'll take that one. Just ask your vet, because so there is a vaccine marketed that's available for animals. It's not available for humans in North America, at least. But dogs generally are symptomatic and get sick. So if your dog's not sick, it's probably not reasonable to do serological assays on them. But do ask your vet about vaccination, and obviously if your dog is sick, then yes, it should be treated. So it needs to be diagnosed, etc.
Okay, thank you very much. I think we'll move on to the second case for the sake of time. Thank you. That was really a fascinating case. Really exciting to hear about what we were seeing at the MUHC. Dr. Yuning Wang and Michael Libman will take on the next case. They're a dairy product. Thanks for being here.
Thank you so much for the introduction. So let's jump into the case. So again, there's no conflicts of interest in this case. And just like Marc-Antoine, I've kept the outline of this presentation for this case to be also very as secretive as possible in order to not reveal the information of the case right away. So let's talk about the case first. So we'll call this patient Mr. B. Mr. B presented to the MGH emergency department around the similar time in the beginning of October, and he presents as a fever in a returning traveler. He has a medical history noticeable for asthma. He's on his typical asthma meds, and he has no known allergies. In terms of his social history, he was born in Algeria, immigrated in 2014 to Canada, and has been living here in Montreal since then. He is a smoker, but otherwise has no alcohol or any recreational or IV drug use. 2 months ago, prior to his presentation in the beginning of October, so in August, he went on a trip to Algeria. And when he was in Algeria, he visited his uncle's farm in the countryside and worked there on the farm. And he notes that he was working with sheep, goats. He ate food that was grown there on the farm. And he also went to the surrounding towns and ate street food. He had no travel to any caves, lakes, or rivers. He had no drug use and no sexual activities when he was present in Algeria. And he also knows that he had been bitten by mosquitoes. And prior to going to his trip, he had no travel medication prophylaxis of any kind. He started having fevers when he came back at the end of August. Initially, it started in the morning, but then it started to become every day. And his highest temperature of fever that he had recorded was around 41 degrees. He also has a company 2-week history of shortness of breath with some productive cough. There's also associated fatigue, weakness, and as well as decreased oral intake. And 2 weeks ago, in the middle of September, he notes that he had some left knee swelling. And because of the left knee swelling, he went to a private orthopedics clinic, and there he had an arthrocentesis that he then tells you only noticed some bloody fluid, but the culture was negative. And at the end of September, he presented to the emergency department with fever, and it was there that he had an initial workup, including having a CT chest that showed some bilateral hilar lymphadenopathy and some non-specific pulmonary nodules. And because nothing was really found and the patient was hemodynamically stable, he was given a course of azithromycin and prednisone and sent home for Cori asthma exacerbation. And so now he presents to the emergency department a week later in the beginning of October again with persistent fevers and as well as persistent left knee swelling. On review of symptoms, the most remarkable thing that's noted is that he had a maculopapular rash that occurred in August while he was in Algeria that covered his arms and his trunk, but that rash had self-resolved and he had no pictures to show us, unfortunately. And so for some other information, the patient has never been vaccinated for COVID-19. This patient had no previous history of tuberculosis exposure. He's not homeless. There's been no trauma of any kind. And he was last sexually active about 6 months ago. On exam, the most notable findings are that he had been persistently febrile since arrival to the emergency department. And he's also been in tachycardia as well, noting that his heart rate had been up to 154 while he had been here in the emerge. On exam wise, his exam was really unremarkable and benign. There was no particular rashes. Cardio and respiratory exam were really not very unremarkable. He did have some coughing, but there was no crackles or wheeze that was noted. There was no lymphadenopathy of any kind. And his left knee was noted to be mildly swollen on exam, but there was no erythema. Routine blood work was done with the most remarkable that of being a mild thrombocytopenia with a platelet of 132. He had a mild acute kidney injury of a creatinine of 115, elevated liver enzymes with an ALT of 76, bilirubin of 30, and then his CRP was also 29.7. The patient shows you his previous clinic that was noticeable for elevated RBC count in the fluid, lymphocyte count of 1,400, and a neutrophil count of 3,500. There was no organisms present on the gram stain. And as part of his workup, he had blood cultures ×4 that was sent an induced sputum for AFBs that was also sent breast viral PCR and as well as malaria smears that were pending. And his COVID-19 swab on both occasions going to the emergency department have been negative. This is a picture. This is one of the sections of the CT abdomen and pelvis. You can see there is this hypodensity that's present in the liver. And this is a CTPE that, as you can see by the markings there, there is a right hilar lymph node that is mildly enlarged. So the patient was admitted to the internal medicine ward with a preliminary diagnosis as fever in a returning traveler, and he was started on ceftriaxone as empiric therapy and given IV fluids. And additional blood work was sent off. So we're not going to go into full details about kind of what the workup for a fever in a returning traveler would be, but note that he had extensive serologies sent off for viral, spirochetes, and essentially a whole bunch of gamut of possible infectious causes were all sent off in order to try and determine what could possibly be causing his fever. During admission, a total of 3 arthrocentesis were performed by the rheumatology service. And on day 3 of admission, the patient's blood culture was positive in all 5 cultures that were done for Brucella melitensis. His PCR was also positive for Brucella, and his synovial fluid that was done during his admission was PCR positive for Brucella as well, though the culture was negative at the time. So this is where I want to then segue and talk about the disease that he had, which is brucellosis. And so first, giving some beginning introductions to what brucellosis is. It's caused by the genus Brucella, and Brucella is a small gram-negative coccal bacilli. And there are 4 species that are of interest to us because they can cause human infection. The most common one is Brucella melitensis, which is usually seen inside small ruminants such as sheep and goats. You have Brucella abortus, which is seen in cattle, Brucella suis, which is in swine, and as well Brucella canis, which is seen in dogs. Some fun trivia fact is that Brucella was first described in soldiers from the British Royal Army Medical Corps in the Crimean War in the 1850s. These patients had a fever that was noted to be transmitted from goat's milk or when they were present near when goats had abortions. And so it was initially nicknamed Malta fever or even undulant fever. Major General Sir David Bruce then first discovered the organism, and he initially had called it Micrococcus, but then later the name was changed to Brucella in order to honor Sir David Bruce, who had first initially discovered the organism itself. And this is a map showing the annual incidence of brucellosis with blue meaning there's less than 2 cases per 1 million population, and red mean more than 500. I've circled where Algeria is. I had to look that up on Google. I wasn't entirely sure where it was, but as you can see, Algeria is kind of in that pretty high elevated zone of 50 to 500 cases. So certainly he does have that epidemiologic background with his trip going to Algeria for concern about brucellosis. The 2 main types of disease states that we want to look at when we talk about brucellosis is one, a zoonotic infection, and you can get infected when you're exposed to tissue and fluids from an infected animal, or if you're ingesting food products and as well as inhalation of infected aerosolized particles. The other way that one can get brucellosis is actually from an occupational risk. So workers who are in the dairy industry, veterinarians, and even in laboratory personnel can also be at risk of getting brucellosis because the organism is quite infectious. So, so those who work inside the microbiology lab, as we'll talk about later, they do definitely carry a risk of being infected with brucellosis should a sample does come in. In terms of the clinical manifestations of brucellosis, initially they can be quite vague. The incubation period is 2 to 4 weeks with very vague symptoms such as fever, malaise, arthralgias. You can get hepatosplenomegaly and as well as lymphadenopathy. Brucellosis can affect virtually almost any organ. The most important ones that I'll highlight here include osteoarticular disease, which is the most common cause of focal brucellosis, and as well as genitourinary disease, which is the second most common presentation of focal brucellosis. Other more rare causes include neurobrucellosis, cardiopulmonary disease, and one can also get uveitis or hepatic / splenic abscesses as well. In terms of lab findings are usually also non-specific. One can get an elevated ALT, anemia, leukopenia, and thrombocytopenia can all occur, and a lymphocytosis can also be present in those who are infected. The diagnosis of brucellosis should be suspected in those with the associated clinical signs and symptoms, but they also should have the relevant epidemiologic exposure. And the way in order to diagnose brucellosis is there's 3 different ways. One can culture it from blood and other body fluids, such as synovial fluid, CSF, urine, or even pleural fluid. Brucella can be detected by PCR, and as well as Brucella antibody titers more than 160 in the serum. So those are all possible ways. Do note that blood culture sensitivity is quite variable. It is 15 to 70%, and as well, when one is doing fluid testing, there is carrying a risk of exposure to Brucella for lab workers who are handling the specimens. The treatment of brucellosis is with doxycycline and gentamicin, or it can be done with doxycycline and rifampin. And generally, the doxycycline would be done for 6 weeks. If one's going with the gentamicin route, then the gentamicin should be given for 7 to 10 days. If patients have spondylitis, then the treatment should be extended to at least 12 weeks. And similarly, with endocarditis, treatment should also be extended to at least 12 weeks. Neurobrucellosis is slightly different, where in the beginning, you would also give ceftriaxone for the first initial 4 to 6 weeks. And you would then continue with rifampin and doxycycline as well in that same duration, and both should be continued for at least 12 weeks minimum. Alternative agents to doxycycline would include ciprofloxacin and as well as Septra that can be used if doxycycline cannot be used. Routine serologic follow-up is actually not useful for guiding duration of therapy, and 15% of cases of Brucella spondylitis will have treatment failure. The main cause of death from brucellosis is endocarditis, should one get infected by it. In terms of our patient, Mr. B, so we had sought the advice of the infectious disease team, and as such, the patient was changed from the ceftriaxone that he had received to doxycycline plus gentamicin. He had received 10 days of gentamicin, and we prescribed him 6 weeks of doxycycline. We had also spoken with the orthopedics team in order to see if there was a need for a knee washout, given that he had left knee involvement, but they felt that it was not needed. He had a transthoracic echocardiogram, which was negative for endocarditis, and also had a PET scan that was negative for any spinal involvement. The patient was discharged on day 11 of admission after receiving his complete course of gentamicin, and he was discharged on doxycycline with follow-up with outpatient infectious disease. He was seen 1 month later after discharge, and he had been noted to be feeling completely better and much improved. His knee swelling had completely resolved at that time. And because it was noted by the infectious disease team that because he had the presence of joint involvement, they wanted him to have 6 more extra weeks of therapy. And so he was given 6 more weeks of doxycycline and also added on rifampin as well. Great, so I will pass this on then to Dr. Libman.
Okay, all right, I'm gonna share my screen. Here we go. Okay, is that my screen?
Yes, we can see your screen. It's
You're
not in presentation mode though, Michael.
It's on presentation mode. All right, let me switch that. Okay, is that better?
Yeah, that works.
Okay, good. All right. Oh, sorry. Let me just switch this for me. All right. Well, I'm going to look sideways. Okay. So the title here is a shout out to a really old show that probably none of you ever remember, but you may remember a show that started Who Knows What Evil Lurks in the Hearts of Men. Well, this is about EO5, which I'm hoping at least a few of you know is in the lab. And I mention that because I am going to talk a little bit, rather than talk about Brucella disease, I'm going to talk a little bit more about Brucella as a lab hazard. So, okay, so another case that actually came to the MGH, this was some years ago. This is a 45-year-old woman. She came from India to visit her family here in Canada. She landed up with what seemed to be a chest wall abscess. She came to the emergency room. They did a little incision and drainage, sent the culture off, and sent the patient home. And she grew this pale gram-negative coccobacillus that was very slow growing, and I'll come back to that, why that's important to know. And the main thing is that the lab sent out a result a little while later as Moraxella phenylpyruvica. And that's the first lesson, of course, is that when the lab gives you something like an abscess identification as Moraxella, as an organism that you've never heard of before, it's probably wrong. And in fact, it took forever to be properly identified, but it was Brucella. The trouble was the amount of time that the lab spent trying to identify it. So Brucella is a zoonosis worldwide, but as you just heard, it's a lot more prevalent in some parts of the world than others, but it is actually a very important cause of lab outbreaks worldwide. In Canada, not much. It may be as much as 2%, but that's just because there isn't that much Brucella here. In areas where Brucella is more common, it remains a really common lab hazard. And if you go and review, there was a review published a few years ago, LAB is lab acquired Brucella, and they described these outbreaks where by putting together all the publications, they had about 170 exposed lab workers with illness in 70 of them. So, and these reports basically had these high attack rates going from 30 up to 100% of the people who were exposed in the lab. And the problem is that even though we associate it in humans with infections related to dairy products and ingestion, that kind of thing, the fact is in the lab, it becomes an aerosolized disease. And I think you've all heard way too much about aerosolized. How much of a risk is it today in a modern lab? Like, I mean, we're really lucky at the Glen that we have a modern facility, and perhaps the way things are put together now, it's a little bit less of a risk, but it's hard to tell. Aerosol, though, in the lab remains a big problem, and this is a classic picture, and of course you all recognize that what's wrong here is that the window should be open. Some of the cases are definitely aerosol, such as cases. There was a reports of cases after a centrifuge tube break, and I think you can imagine that if a tube breaks in a centrifuge, that's a perfect way to generate big time aerosols. And they had cases among people who were not in the room at the time of the accident and who came into the room only later. So that's a classic proof of aerosolized transport. What are the kinds of things that we do in the lab that generate aerosols? If this wasn't a Zoom talk, I would have to ask all of you people how many of you have done these kinds of things when you had a chance. So you may know, very traditionally, labs all had Bunsen burners, and we used them all the time because we had these little things called loops, which we used to transfer colonies of organisms from agar to other media and so on. And we would sterilize the loop in between transfers by heating it over a Bunsen burner. And actually just heating it on the Bunsen burner, although you think that's a great way to sterilize things, in fact, transiently, it causes a bubbling and creates aerosol. The sterilization procedure actually creates an aerosol. We don't actually have Bunsen burners anymore in our new lab. We use these other contraptions that you see here on the right. You can see a really new one. I think it dates from the Paleolithic era. It's a incinerator that we use, and it doesn't generate that same kind of aerosolization. This is just an example of how microbiology labs, a lot of what we do, it's changing now, but a lot of what we do really hasn't changed much since the time of Pasteur. It is true, though, that with molecular techniques in particular, we are becoming a lab filled with machines where all you have to do is kind of press buttons. So we're kind of slowly turning into biochemists. Oh, sorry, I should have probably checked that there weren't any biochemists in the audience. Other things that we do to create aerosols, we mix things up using these kind of vortex machines, and we'd still do a fair bit of vortexing. This is with a cap, which is really what you should do, but a lot of times just as a quick mix, the techs will use a vortex machine without necessarily a cap, and that can generate aerosol. We do tests, like this is what's known as a catalase test, where we make a little emulsion of the colony and mix it with hydrogen peroxide and show the presence of catalase by this bubbling action. I think you can appreciate that that can generate some aerosols. The real problem, though, that we had in the lab, and that has more or less, I hope, stopped happening, is the fact that it was commonly a common practice to smell agar plates as a way of identifying what the organism was. A lot of organisms have very characteristic smells, and in fact, it's not just a lab thing. You can sometimes, even in a patient's room, if there's been an abscess that's drained or whatever, the smell, if you pay attention and if you know some of the background, some of the smell of the organisms, you can actually pick up a good hint for what the organism might be. We try and tell lab techs not to sniff plates anymore, but it still happens because it is a relatively easy way. I pulled this off the internet. This is, as you can see, a current website, and it's an online teaching course in microbiology. And again, it talks about microbiology for beginners, and it talks about microbes with good and bad smells. Obviously, the only way to know that is to actually sniff them. Just by the way, in case you're interested, some of the types of smells. Some of the classic ones are Pseudomonas, which it smells like grapes, a sweetish, fruity smell like grapes, and you can definitely smell that from an abscess or that kind of thing. Strep anginosus, or the group of microaerophilic strep, have a butterscotch kind of smell. Eikenella smells a bit like bleach. Pasteurella classically smells like wet mice. I don't know exactly how many people know what wet mice smell like and how they decided, but Pasteurella, when you smell it, you can imagine it smells like wet mice. Candida, yeast, smell like yeast. C. diff smells like horse manure, and more Brucella in the textbooks smells like semen. Don't ask me who figured that one out. So Brucella, some of the problems we have in the lab is that it grows very slowly. And one of the problems is that if you don't tell the lab you're looking for Brucella, we might miss it, because blood cultures, we only hold blood cultures normally for 5 days. And in blood culture bottles, it can take more than that for Brucella to grow. On plates, it can take 72 hours, and we don't always hold the plates that long, depending on what culture was asked. The fact is that, and the organisms are small, they don't stain very well. Some inexperienced people can miss them. It's very non-reactive in most of the standard kinds of biochemical tests. So a lot of the reason years ago we got that MUHC cell identification is because the non-reactive type of organisms cause us a lot of problems for identification. We now, some of you may know, we have a new, very expensive machine to do bacterial identification known as MALDI-TOF, matrix-assisted laser desorption and ionization time of flight. It doesn't depend on biochemical tests. It's a protein type of fingerprint. And in fact, supposedly, according to the literature, about 90% of Brucella should be properly identified by the technique that we have now. I don't understand. Nobody understands this, how this technique works. I think the Martians left it when they visited after they took over the US government. Brucella should normally be handled in biosafety level 3 facilities. What's biosafety level 3? Biosafety level 3 is a type of safety structure within labs. It's used to control aerosols, and there are actually very few biosafety level 3 labs. There is a biosafety level 4, by the way, for things like Ebola. We have only one such lab in the country, in Winnipeg, in fact. But most places, most labs, at least smaller ones, don't have a level 3 lab. It's used mostly for TB, has a very complicated air handling structure and design and airlocks and stuff like that. So it's a complicated kind of system, and almost all our regular work is done under biosafety level 2. We do try and get a lot of potentially aerosol generating maneuvers done inside a safety cabinet, but everything else, if you've ever walked into the lab, you'll see it's generally done on an open bench. So back to that case, we had, at the time that abscess was being worked on, we had 26 techs present in the lab while that specimen was being handled. 6 of them manipulated the plates in the colonies directly, and most of them, of those 6, admitted that they had also sniffed the plates in trying to figure out what it was. One of them was actually pregnant in the 2nd trimester. Important because it wasn't mentioned, but Brucella in a pregnant woman is generally bad. There's a fairly high spontaneous abortion rate and intrauterine fetal demise. We'd offered, after this exposure, we offered all the 26 techs present in the lab at that time to do serial serologies on them, with the idea that perhaps we could catch an infection before it became symptomatic. And the people accepted to variable degrees, but the adherence to that didn't really work all that well. For the 6 that handled the plate, we offered them prophylactic treatment. 4 of them got doxy and RIF for 3 weeks, so it's really a full treatment. And the pregnant tech was treated with Septra, and 1 of the 6 declined. And 10 weeks later, the tech who declined had fevers up to 40, waited 5 days at home to come to the emergency room because she felt too sick. And her blood culture, when she eventually came, grew in 3 days. The serology screening didn't actually increase. We didn't see an increase in serology in anybody in this patient prior to the fever, so that didn't work. And then generally in the literature since that time, doing serial serologies as a preemptive kind of measure doesn't really work very well. But at least the tech who was sick did do well on doxy and genta, and in fact still works in the lab and still drives everybody crazy. Everyone who took prophylaxis remained well, and we published this little series, which is one of the few kind of natural experiments in prophylaxis. Nobody had significant problems with the treatment, and no one else seroconverted. So what we learned, and what I'd like you to learn, is that It'd be really helpful if clinicians gave the lab an idea more frequently, the kinds of things they're looking for. It helps us do the right tests. So for Brucella, for example, if you tell us you're thinking about Brucella, we'll hold the blood cultures for a longer time. It protects the techs from potential exposures. Because, and unfortunately, we don't have a good way with our order entry system. We don't have a good way of transmitting this kind of information to the lab, and it's a problem. The other thing, of course, is that clinicians are not all that familiar with Brucella, so they may not know ahead of time they're looking for Brucella. Inside the lab, we try and get the techs to be alert to this kind of organism, these pale staining, slow growing organisms, and if they notice something like this, they're supposed to be careful. One of the problems that's happened recently, though, and including with the case that you just heard about, is that we've lost a lot of our senior lab staff from after COVID. People retired en masse. And it's affected our ability to really properly supervise and train some of our new recruits. And so we did have another exposure related to this case, another exposure in the lab, thankfully, with nobody exposed. So we always try for universal type precautions to do the same thing with all organisms, but we can't do that all the time. I like this picture. It's off the internet, but it's the first thing you want to do is wear your gloves properly. Wear gloves that fit. I don't know what this is all about. You don't pour stuff from big vials into little tiny tubes. That's a bad thing. And of course, you never handle anything that color of blue. That's just got to be bad for you. So Brucella, just things to remember that are different from a lot of other bacterial disease. This long incubation period, it goes sometimes as much as 12 weeks. So the incubation, I'm trying to link it potentially with previous travel. It's not just very recent travel, it can be months ago. This very undifferentiated fever that can persist for a long time, clues often that it becomes undulating. But it can affect any organ, abscesses anywhere. CBC is often normal, and a normal CBC in the presence of a high fever is not normal. Hepatosplenomegaly is one of the clues that comes up after a little while, and skeletal infections, bone and joint, are common. Again, there are current blood culture machines. Most of the time we can pick it up, but if you tell us, it helps. Even serology can be a little difficult to interpret. So if you tell us, it can help. And the last thing I want to show in terms of lab safety. So this is from the lab. If you go up to EO5 on the left side here, you see one of our fire exits, an exit that's supposed to be kept completely clear of all obstruction. And you can see it completely filled floor to ceiling with COVID testing reagents that we had no other place for in these last couple of years. And the picture on the right is actually our emergency shower. So we're really a little short on space. And that's it. I'm gonna stop my share.
Thank you so much. Thank you to all of you, the four of you, for presenting really fascinating cases. And once again, it's really great to see the variety of cases that we're getting at the MUHC. Cedric, I think you were responding to the question there by Ariel. I don't know if you want to make a comment. We have a couple of minutes left. Cedric, you want to say a few words?
Sure. I just wanted to save Mike some time, but there was a question, a very good question about whether drawing clinical aspirates of joint fluid could be a risk to the rheumatology team when they're examining specimens. And I was just saying that in general, clinical specimens are not considered nearly as great a risk, because by comparison, a culture amplified specimen has about 10 to the 12-fold more bacteria per ml or per volume unit than a clinical specimen. So that's why laboratory acquired infections generally have a higher attack rate and a much higher mortality than community acquired infections or naturally acquired infections with the same organism. So, you should always use proper procedures and make sure that you don't lick the slides and clean the bench before and after you use it. But in general, clinical specimens are not the risk in general.
No, I can tell you in lab, in the good old days, their techs used to eat lunch on the bench with the plates. They used to smoke in the lab, and cigarette ash would fall into the agar. Mouth pipetting, all these things were surprisingly common, and yet hardly anyone died.
Hardly anyone.
Thank you. Thank you for sharing that with us, Mike. Well, it is coming on the hour, so any questions will have to go offline, but I do thank you very much for sharing these terrific cases with us. And Michael, we clearly have to find a way to make sure that we transmit the information to the lab when there are these sort of risky specimens. And again, it's something that we can talk about offline so that we can reduce the risk of everyone involved, everyone working here. So thanks very much, everyone, for joining us, and I wish you all a great afternoon. I'll ask the team if they can stay online if there's any questions that come in into the chat, but we will have to close the session. Thanks, everyone. Have a good afternoon. Bye-bye.